Greetings and welcome to this module on antibiotic series. In this video, we'll discuss about the stoppage, de-escalation, and the duration of an ideal antibiotic therapy. So, if you have worked in a good ICU setup where you will be stressed about stopping an antibiotic when the role is over, or to de-escalate to an appropriate antibiotic from a broad spectrum or a higher spectrum antibiotic to a narrower spectrum antibiotic to target that organism and to prevent resistance organisms. So, if you have not worked in an ICU setup or in general medicine setup in such a place, then you create such a place. After watching this video, you'll be confident in doing so. So the moment you start an antibiotic, you must already know when and how to stop that antibiotic. That's where a physician or a critical care physician stands apart. So antibiotic stewardship, like an IDSA policymaker, we will discuss in this video. So this is completely for educational purposes and for practicing physicians. This is Medicine Beyond Harrison's. Let's get started. So, why antibiotic stopping or the stewardship is important? It's because more than 50% of antibiotic days in the hospitals are unnecessary as per IDSA. This is the hard truth, and is followed by most hospitals. They do not stop an antibiotic when it is not appropriate, and they unwantedly stop an antibiotic or go for a higher spectrum antibiotic when a lower spectrum antibiotic is sensitive. They just directly go for meropenem or imipenem or a ceftazidime-avibactam when the even a cefoperazone or a ceftriaxone is susceptible. So all these mistakes you should not do. After watching this video, you should be confident in stopping or de-escalation of an antibiotic. So the harm is dose into duration dependent. So more the dose and more the duration, there will be more harm to the either the renal kidneys or for the liver. So resistance is driven more by the duration than by the choice. So the choice of antibiotic is not the more prone for developing resistance. It is the duration, the inappropriate duration. For when you must know when to stop an antibiotic. So for pyelonephritis, 7 to 10 days. More than 10 days, there is no role. For an bacteremia alone, it is for 7 days. No, not more than 7 days. These are the general rules, but can be modified according to the clinical setup where you are in and the host dependent as well as the organism dependent. So more the duration, more the resistance, and not it is more about the duration than about the drug itself. So starting antibiotics saves this patient, whereas stopping them correctly saves all future patients. So remember that you'll always get a future patient, and you must know how to treat that patient. So starting the appropriate antibiotic for this patient saves him, and de-escalation and when to stop it you must know, and to stop it accordingly to save all future patients. This is the prime stewardship principle you must keep in mind. So antibiotic time axis. So when a policymaker creates an antibiotic or in the development process of treating an organism, so most doctors are correct in starting an empiric antibiotic. So this is the time zero where we start an empiric antibiotic, be it tazobactam, be it cefoperazone sulbactam, be it ceftriaxone, even be it meropenem, or even just directly going for a polymyxin, or covering for an MRSA, covering for an MSSA. All those things can be started as an empiric. So these most doctors do correctly. So the most important time is where the expert shines is that the reassessment phase in the time duration of 48 to 72 hours. So in these 48 to 72 hours, you must have obtained the culture reports. So before starting an empiric antibiotic therapy, it is mandatory to take cultures, at least two sets of blood cultures to obtain a yield of at least 95 to 97 percentage. Three sets of blood cultures yields a 99 percentage sensitivity to detect an organism in the bloodstream. So this timeline where 40 to 72 hours where most doctors and critical care consultants fail. This is the expert window. You must know to reassess based on the culture reports. If the culture is not coming, you must know to follow up the culture report and ask for the microbiologist to specifically incubate if based on the clinical context and the time of the end. This is where you must know stop the antibiotic. So there's no point in giving antivirals just a time you do more than 5 days. Also, there are exceptions for giving it for 10 days in few cases. If you have not watched the video on influenza approach, please go and watch that video. It is in the infectious disease playlist. So you must know when to stop an antibiotic. That's where you shine. So you must always at the 48 to 72 hour, you must ask whether there is a proof of infection. So by this time you should have obtained your cultures. If it is positive, you can continue. You could have got the radiological reports and you can have seen the films and discussed with the radiologist, and you must ascertain whether it is an infection or not. Clinical response to antibiotic and the improvement on the patient in the first 48 to 72 hours decides whether he needs more antibiotics or you can just stop it. So whether there is an alternative diagnosis explaining the clinical presentation rather than an infection. We must ask these four questions: culture, radiology, clinical response, and alternative diagnosis. All these questions you must keep in mind to ask every single day in the morning rounds whether to continue an antibiotic or not. So, continuing an antibiotic may save this patient, but inappropriately continuing an antibiotic kills the future patient. So, stop it if there is no infection. But just not go with an idea that you must always complete 5 days once you start an antibiotic. Not like that. So don't just put an antibiotic just in case whether it is an infection. Not like that. So if you have known that there is no infection with all these four questions answered as no, 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 then you can definitely stop an antibiotic. So organisms. So apply sessions like we have already put a videos on resistant mechanisms of organisms, the CSBA, LAMC, MRSA, and whether it is a contaminant. If not, go back and watch the videos number 2, 3, 4 on this playlist. So this determines the eligibility of whether to continue with the same antibiotic or you can de-escalate or whether you have to upgrade. So you must always choose the narrowest spectrum of antibiotic with the proven outcomes with the best pharmacokinetic and dynamic for that organism and that host with the lowest possible collateral damage. Some people will have already existing CKD or an heart failure or liver disease. In all those patients, you must know what antibiotic to choose for how much duration in the best pharmacokinetic and dynamic administration approach and like known outcomes. So to know about more about the pharmacokinetic and dynamic approach, we have separately put a video on this series. You can go and watch that. So you must also note in choose the narrow spectrum. For example, for an suspected gram positive or an Staphylococcus bacteremia with an endocarditis. So initially you start on vancomycin. Later you obtain a culture report as methicillin sensitive staph aureus. You can definitely go in for an cefazolin or flucloxacillin, and you must know to de-escalate or convert the vancomycin to cefazolin, that you must know and narrow the spectrum of activity against that organisms. So de-escalation is not the right word, as we said. It is actually the upgrade in precision to that organism. That is actually the upgrade. So de-escalation is the most feared skill that most physicians or clinicians face in the ICU or in the ward setup. You must know to de-escalate. That is where you shine. So why we resist de-escalation is because fear of deterioration. The patient is already getting improved. So now why should I de-escalate? If you ask that question, that is where you are in fear of the deterioration. You must not do that. And ego. So there is some idea that broad spectrum is the powerful drug. Not like that. Never. So narrow spectrum targeting that drug, that organism is the powerful antibiotic and the definitive therapy for that organism and the host. And it is not the broad spectrum that is a definitive therapy. And the past anecdotes also go in for previously the physician might have a bad experience of de-escalating that will creep into his mind and lead to failure of de-escalation. So what IDSA says is that failure to de-escalate is a quality failure of that hospital or ICU setup. So always know when to de-escalate and de-escalate accordingly. So you must always convert the broad spectrum into the narrow spectrum after obtaining cultures, and you must know when to convert an IV drug to an oral drug and then when to discharge, and combination drug to a single monotherapy whenever possible, and antibiotic stopping of antibiotic. So all these four things count when you start an antibiotic. So you must know to convert broad spectrum to narrow spectrum IV into oral, then combination drugs such as in some few cases we give ceftriaxone and metronidazole for an acute gastroenteritis. In such cases, you must know stop, metronidazole when there is no other parasitic or there is no oasis in the stool routine. You must know to stop metronidazole. And when you're not suspecting any anaerobic organisms in that, you must know to stop metronidazole and you can continue in ceftriaxone. That too for a definitive period where you obtain the cultures when there is no salmonella typhi and the stool routine suggestive of viral, then you must not stop that also. So stopping is the next thing. All these four things count. Safety checklist, there must be all these must be true. So for before de-escalation, there should be hemodynamic stability. The patient should be improving clinically. The source must be controlled, and the pathogen should be identified or infection is ruled out. All these things should be true for you go in for a de-escalation. So you must know when to de-escalate, and you must know when to keep the patient in the broad spectrum antibiotic. And finally, come towards to a conclusion that this drug is the definitive therapy for this organism and the host. So duration. So most people say that you must give a 14-day therapy for an infection. Nothing like that. Those are all myths. So there is no. It is treat until resolution and not until calendar satisfaction is the prime idea or the logic. So for community acquired pneumonia, most commonly 5-day therapy with antibiotics is mostly sufficient. And skin and soft tissue infection, if uncomplicated, may need 5 to 7 days of therapy. Intra-abdominal for 4 to 7 days. Then you must stop. Urosepsis 7 days, and then you must stop. Ventilator-associated pneumonia or hospital-acquired pneumonia, treat for 7 days for the maximum duration, then stop and see for the response. Gram-negative bacteremia, give for 7 days, and then you must know to stop. So, and for pyelonephritis, after 10 days you can go. Another more than that, there is no point in giving an antibiotics. The more the duration, more the development of resistance. You must know when to stop an antibiotic. So longer duration leads to increased resistance. This you must keep in mind. Increased Clostridium difficile infection, increased acute kidney injury, and there is no reduction in relapse of the infection. So longer is not at all equal to better outcome. So the timeline is very important to prevent formation of resistance as the first foremost stewardship approach. So when not to stop, there are a few conditions where you can continue more than 7 days, more than 14 days. These are the specific infections where you must continue for more than 14 days, as recommended by IDSA also. For endocarditis, for osteomyelitis, for undrained abscess, for immunosuppressed patients with poor response and persistent bacteremia, with second positive culture report, also you can continue. So specifically in cases of Staphylococcus aureus bacteremia, if you have started on the cephalosporin, ideal guideline is to take in culture every second day or every alternate day, and you must continue antibiotics for 14 days from the day of first negative blood culture. So that is how few treatment guidelines are there for few organisms. We'll discuss all those things in subsequent modules. So these are the few indications. These are the almost end. These are the very few indications where you need to give a longer therapy. So these are exceptions and not defaults. In these cases also, if there is a clinical response and resolution, you can stop. So, for example, you have a urosepsis case. You started on piperacillin toxoplasm bacterium or cephalosporin cell bacterium as a broad empiric therapy, which is acceptable. So, at 48 to 72 hours, you obtained the culture report as non-ESBL E. coli. And the patient is also stable. The sources of culture to be urine also positive. Then you can definitely de-escalate that to ceftriaxone. Ceftriaxone is mostly sensitive. So you must know to stop at stop at 7 days in total and can consider oral step down. Anything else will lead to overtreatment. So you must know when to stop. So stop antibiotic at 7 days. So the five deadly sins and the audit. So these are the five sins that commonly are followed in medical practice or in the ICU setups. These should not be followed. So there is an idea that let's complete 14 days of therapy. What's going to happen for continuing for 4 more days? It is the common misconception. 4 more days will lead to increase in the resistance development in the organisms. So because the patient is elderly, you can give for more days. That is also wrong. If the fever comes back, when the fever comes back, they suggest some other infection and not the same infection. So consultant X always gives longer, so you should must not do that. So whenever a consultant do that, you must inform them about the antibiotic stewardship and ensure that your ICU setup or your ward setup is following all those things properly. So we have already started. When let's finish. This is also a common misconception. When you are started and when you know that it is not an infection, you must stop it at that moment itself. So none are scientific arguments. So these are not at all scientific arguments. So you must stop in all these cases. So every order of an antibiotic in the case sheet must contain indication why that antibiotic is started, the empiric versus definitive therapy, which is the empiric therapy and which is the definitive therapy that finally you have in transition to, and when are you going to stop that antibiotic, and when is the de-escalation plan, and when is the review date for that antibiotic and the patient case. So this must be there in every order. So finally, starting antibiotics is easy. Stopping them correctly is the expertise. So we must be an expert in using an antibiotic. That's where the excellent physician shines. So, for example, a septic patient improved dramatically in 48 hours. Cultures are negative, CRP is falling, and imaging is clear. So, why stopping here is more correct than continuing 5 days in just in case. This is mainly done when you know properly about the antibiotic stewardship. So, we learned a lot about antibiotic stewardship and the common practical use cases of all those things in your wards or ICU setup. If you have liked this video, please give a like, and if you're not first time for this channel, do subscribe. We'll go more in detail about individual antibiotics and the specific organisms and the type of antibiotic that we give to treat all those cases in the upcoming modules. This is Medicine Beyond Harrison's. Thank you for watching.